Alzheimer Society here in Northern Ireland in public affairs, policy and campaigning. Can I be heard? Yes? Okay.
You can.
I'm going to keep it kind of brief because, for obvious reasons, the points I want to make are about people with dementia and health services in very generic terms. I'm not pointing at fingers at anybody, and I want to say at the beginning, good care for people with dementia does happen, just doesn't happen enough. So, Alzheimer Society basically is a support and research charity, and we provide information through publications, helpline, website, etc. We also campaign for change for people with dementia so that their quality of life can be better, the quality of services they receive in any setting can be improved. And I'll probably touch on just three things in the course of my brief talk this afternoon, and one of them is really about the scale of dementia, which you probably hear about quite a lot in the news recently. There's been a recent report where the figures have been updated since the last Dementia UK report. There are now 8,350 people 853,000, my figures are not, my sums aren't good, in the UK with dementia, and 19,765 here in Northern Ireland. The figures kind of speak for themselves, you know. The cost to the UK economy is thought to be somewhere in the nature of £28 billion, and we can't actually cost the cost to people themselves who have dementia and their families. But we can certainly guess at it, and we certainly hear from a lot of people with dementia through our services and through our campaigning work, so that's something that we really want to work very hard on. Diagnosis rates, which are probably comparably not very good, but much better than in England and Wales. They're better here in Northern Ireland. People have hazarded a guess on why that happens, and some of it may be something to do with our integrated health and social care, but if it were that, it would be equally good right across all the trusts, and it is, and they aren't. The Northern Trust has a relatively low diagnosis rate. I'm not saying that just because we're here, but it just is a matter of fact, and the Belfast Trust has a relatively high rate. The average in Northern Ireland is 63% diagnosis rate, and the importance of diagnosis rate really can't be emphasised. It is really the door to getting information, care and support that people need as early as possible, to keep them in good health, to keep them well and independent, to keep them out of emergency services, to keep them out of hospitals, and to delay for as long as possible the need to go into long-term care, maybe close to the end of their lives. I think the implications of diagnosis are very, very serious. People also have a right to know that they have a condition which is as serious as dementia, and because of the nature of dementia, and it gets worse over time, and there are huge issues around cognitive impairment and eventual lack of capacity to make decisions, that the most important thing is that you get a diagnosis early, that you get the support early, and also that you have time and the support services you need to come to terms with the diagnosis, because it's a huge, very, very serious emotional time in a person's life, but also that you can plan for the future. And many of you will be aware that the Mental Capacity Act is currently in development, and that has very, very serious implications for people with dementia, and we are very keen to see a very strong mental capacity bill, which actually has advanced decisions in it. Now, the bill team are inclined at the moment not to include advanced decisions in the bill itself, to leave it in common law. We will be arguing against that because we feel that this will weaken the possibility or the probability of people using advanced decisions and making decisions for themselves when they're well, for a time when they can no longer make them, and to make sure that health care professionals follow their wishes and their views, and that they are acted upon. So I think maybe, apart from maybe just saying that, just to give you a little scale of the services that people use, about 70% of care home residents have some form of dementia or a very significant memory impairment. 1 in 4 hospital beds are occupied by a person with dementia over the age of 65. And I think the figure of the 28 billion spent annually is a very critical one, but note 11 billion per year is probably accounted for by carers and families contribution. That's a huge contribution from carers and families, so that's another issue also. I think basically, certainly having listened to people speaking this afternoon, we're all talking about some of the same issues in terms of workforce, skills, expertise, time, and the occasion to be able to care for people as well as you'd like to do it. Medical professionals don't go into that career in order to ignore people. They really want to do the job well, mostly. And I think making sure that the health service gives them the apparatus to do that and the occasion to do it, I think that's really what we're hoping for. So I'll just stop there. I'm not sure if I did 10 minutes.
Nope, your timing is great and impeccable. Liz, I'm going to ask you a couple of questions first. I'm going to pick up on a couple of issues that you've raised in your statement. You said there's a relatively low rate of diagnosis of dementia in the Northern Trust compared to the Belfast Trust. I wonder if you'd say a little bit more about why you think that is, what it is that creates that variation, and is that, my second question around this is that something that is particular to Northern Ireland, or given that you're a UK-wide service, for example, if you went to Scotland, Wales and England, would you see exactly the same kind of variations between one hospital and another? Or
well, we don't actually do it by hospital, we do it by trust and by constituency. Our most recent report, which was published in September the 10th, our new prevalence figures, formulates them by constituency. That had the two reasons for that. One is that we want MLAs, who are our legislators and the people who are generally in charge and of policy making, etc., at the highest levels. We want them to be aware that they have responsibilities here and that their constituents are actually people with dementia and their families as well. Now, as to the divergence, I don't think we know the answer. When we look at the broad figures for Northern Ireland, 63% is very high. In average terms, 63% of people with dementia having a diagnosis. In Belfast Health Trust, it's 75%. Now that's hugely, I think that's right up at the top across all of the health authorities in England, Wales and Northern Ireland. I'm not sure about Scotland. So people were inclined to say very glibly, well, it's because of the health and social care being integrated. Yeah. But you can't say that if there's a huge diversity. I mean, 52% in the Northern Trust and 75% in Belfast. You can't say that that is because of an integrated system unless there's a huge rural-urban divide, which there could be. The frank answer is we don't know. We haven't done enough research. All kinds of speculations have happened about it, but we don't have an answer. And certainly the dementia strategy goes some way to trying to promote, increase in diagnosis rates, but it has been, well, up to now, underfunded. I know the minister, the day before he left, threw some money at it, but it has been underfunded, and I think it shows in the implementation of it, and part of that dementia strategy focused in on getting diagnosis rates and having the experience of having a diagnosis and being supported immediately after it as being very critical to people's welfare and well-being from then on. It can slow down having a good experience at a diagnosis stage and being properly cared for and properly informed immediately afterwards, and your family supported, etc., can make all the difference to extending the period when you are in really as good fettle as you can be, and living life to the full and enjoying your life.
And it's just a supplementary of this. Is the Alzheimer Society doing any work to try and drill down to work out why Belfast is up there at the top of the class, so to speak, and another trust is... Not yet, but it's an idea. I'll bring that back to our director. Okay.
We do research, and I think it's probably one that people have thought it would be worth doing because it will have implications right across the board, across. Yeah.
My second question relates to, and we'll come to participation and involvement from others, but your sense from the work that the Society is doing, this inquiry is obviously about the emergency department, but it's very much around, and a lot has been talked about to date in the inquiry about the whole systems approach, therefore out-of-hours GP services, minor injury units, the emergency department, community care, and kind of step-down care and all of those things. From your perspective, looking at all of those things that affect the emergency department and the emergency department itself, what do you think are the key resource issues for people with dementia, and what are the key non-resource issues? And I'm thinking of looking here as well then at what are the things that you think should happen or would like to happen in both of those areas, things that can be sorted by resources and things that actually aren't about resources but are about other issues.
I think probably immediately the most key resource issue will be about making sure that people have the care and information and support they need early and at home while they're still well, to keep them well. And that's kind of, domiciliary care, home care, whatever you want to call it, making sure that you have the facilities to support. I mean, I should have started by telling you that really that dementia is kind of an umbrella term, for all kinds of illnesses arising from, it's chemical and structural changes in the brain arising from things like Alzheimer's. Now, it has huge complexity in the way it affects a person, and a person's reaction to dementia will be very different depending on their own resilience, their own strength, and also the networks around them. And the networks around them are very important. If you have a supportive family and friends and pals and neighbours, that can make a huge difference because you continue to do some of the things that you always did, that you always enjoyed. And that's a very big part of keeping people well early on. It doesn't come under the banner of health with a capital H. It comes under the banner of social care, being involved in your community, not being marginalised simply because you have a medical condition. And that can have a very, very big knock-on effect. Keeping people well and in their community, I think that's probably the most critical one, because at the early stages of dementia, a person's needs are very slight, but they're very important. It's very important to meet those needs at that early stage, because a bad habit of being isolated or being left out of things or being excluded or not being asked about your view on things, it will just go downhill, There's no other way. There's no way back from that. What was the second part of the question?
It was the resource and the non-resource issues. What do you think are the key resource and non-resource issues?
Well,
and then any kind of
I think the resource, another resource issue, key resource issue, is really about expertise in care staff. People have spoken very touchingly about their experience in a hospital today, and you imagine you go into a hospital which is a busy, frenetic, stressful environment. You're not feeling the best anyway, and then you add dementia onto that. If you are being cared for by a person or persons who don't have a lot of understanding or expertise in dementia, they are not going to be able to support you or to comfort you or to mitigate some of the worst effects of that extraordinary environment. They're not going to be able to be helpful to you if they don't even recognise dementia as being something that they have to think about. And a lot of people will go into hospital, say because of an accident or a fall or maybe a urinary tract infection or something like that. And people will think that's what they're here for, and they will almost, their dementia is incidental. And it's kind of missed, or not really missed, but kind of ignored. And that is critical. I think just expertise, workforce training, but also time and I mean, people talk about, simple things like somebody in a caring profession sitting down beside someone in a bed and looking through a magazine with them. Simple little thing that makes somebody feel I'm not alone, I'm not being cared for by people who are just rushing past. And when you have dementia and you're in a busy ward, you could very easily get rushed past because you can't hail people, maybe your timing's not right, things like that, and you can very easily be isolated. So the expertise of people who are caring for people in any kind of emergency care or in a hospital ward is critical to their first not getting worse and getting out of there very fast. I mean, the information that we have from our report, Counting the Cost, was that people who have dementia or are in a hospital, they stay longer than people for their counterparts with similar conditions. Their condition, both their condition that they came in to have treated, but also their dementia deteriorates. And if they have come into, if they've been admitted to hospital from their own home, they're much more at risk of being discharged into a care home afterwards. So that's a huge negative impact of failure.
Can I kind of narrow down, because the inquiry is obviously the emergency department and the things that impact on the emergency department. So I wonder if there are anything within that purview of our inquiry.
I think in terms of the emergency situations, everything is amplified. A lot of your speakers have spoken about that. Mm-hmm. It's kind of red hot. Everybody is frightened or disturbed and fearful, and I think just everything that I've said is amplified in an emergency situation. Now, the Alzheimer Society is currently doing some work in a program called Dementia Friendly Communities, and it's really about extending our view of what the critical things are for people with dementia beyond the health with a capital H, and it's about creating communities which are good places for people to live, where they can access services easily and where they are included in their communities. And a critical part of that work is they are working to raise awareness with fire services, with ambulance services, and with police services, because they are often the first people who come on the scene in an emergency, and for them to be able to communicate really well with a person with dementia, understanding the condition a little bit more, can just make all the difference between a person's condition deteriorating markedly and very fast before they even get into emergency care, or actually, mitigating some of the effects of their condition and supporting them to hold on till they get that emergency care from specialists,
Okay. Final question for me. One of the areas that we've discussed has been end-of-life care. And one of the things we've heard on a number of occasions has been the number of people who have been transferred from nursing home care to hospital when it's been clear they're probably dying.
Just dying.
And essentially then whether actually the right place for that end-of-life care should be a hospital emergency department with all the difficulties there, as opposed to actually in the nursing home itself. And I wondered if that's an issue that is an issue for the Alzheimer Society, and if it is, have you any thoughts on how you deal with that in the most appropriate and humane way, given that identifying whether somebody is at the end of their life is not an exact science?
Yes. We have done quite a bit of work around end-of-life care, as you can probably imagine. Yeah. And that issue of people tell us all the time, I want to die at home. And if home is a care home, and care homes should be home if you're living in one, it's not an institution, dying at home in your own bed, in a care home or at home, is important to people. It's not happening enough, and part of the reasons it's not happening enough is that people are not, in some ways people fear the business of death. They have an aversion to dealing with it. It's just an ordinary part of life. We're all going to go there at some point. But also, I think there may be issues around how care homes are set up as almost like sort of hotels in some ways. And I think they need to think in terms of... And also, care homes are in the community, and they need to be able to call in specialists when their residents are ill. They need to be able to call in the specialist, and they need to come and visit them, and do, that specialist dementia expertise can help people in care homes who are presumably, some of them, at least some part of the team, are medically qualified, to ease that person through that process, to provide the conditions where they can have a good death, where their family or the people they care about are around them, because that is very important both to the person who's dying, obviously, but also to the people who are close to them, because that feeling that somebody you loved had a bad death, where they were in the wrong place, in a noisy environment, you couldn't talk to them, is a terrible thing to live with afterwards. And we certainly would be promoting the issue that people at the end of your life is as important as the beginning and the middle. that it is very important that people get that care.
And are there any demonstration projects or models or kind of outstanding examples of where actually a much better approach is happening, or is this something that really is not being addressed?
I think these
else?
things are happening internationally. I can't actually name any of the particular projects, but I can certainly get you that information and send it to you, helpful. Okay? Because it is not impossible, and it's been proved not to be impossible. And when it happens, it's really positive, you know. So I can get you that.
That's lovely. Marion.
Good afternoon, Elizabeth. I have only one question, and it relates to how patients and carers are involved in the planning, delivery and evaluation of services for dementia patients, and including reference to the 10,000 Voices project, but not focusing totally on that. And have you any suggestions on how you could develop or improve their participation?
Well, the Alzheimer Society at the moment is setting up a group of people with dementia, and it's at the very early stages. But we have, over the years, had several key pieces of work where we've actually done research, qualitative research with people with dementia. I mean, we did the Listening Well report with the Mental Health Foundation in 2009, which was to prepare for the development of the dementia strategy. And that was with a very small cohort of people. I think there were 7 people. They were all living with dementia throughout Northern Ireland. And of course, we had the Mental Health Foundation in there with us, and they are stalwarts at that kind of exercise. But we facilitated it, and we supported people to engage in it, and we communicated with as many people as we knew of, and asked them if they'd like to be involved. And we did what we needed to do in order to make it possible for them. All of the practicalities of being involved are just amplified a little bit for people with dementia. You're not at your best at certain times of the day and things like that. So all those things have to be taken into consideration. But our experience of, say, certainly working on the Listening Well project, and also in working with people when we're doing media work, where we want people to be supported so they can talk to camera, you know, and talk in media work, because it's so important to see people with dementia and family carers talking about their very personal experience. It breaks down all those barriers. If I'm at home and I'm caring for somebody, or I have early stage dementia, and I see somebody who's in a similar situation to me speaking on the UTV news or the BBC news, it changes my attitude. I start thinking differently about myself and my own capacities, and that's very important. That involvement has to be very public and very obvious, but it also has to be very sensitively done. We've found it very good to do, as I say, in the Listening Well project, but also we are day and daily connecting with people with dementia and with family carers in order to develop our policy work. And you know, we will talk to people about things. Say the most recent thing was the mental capacity consultation. You know, we try to have one-to-one conversations with people about their views on issues that are coming up. But as I say, we're setting up a group now which will be a standalone group. We will basically be their secretariat. We will be supporting them to do things that they want to do and to input into all kinds of useful fora, but they will choose what they want to do, and we will do the secretariat part. We'll do the dirty work.
Thank you very much.
But it's at the very early stages, so I can't tell you anything about how successful it's been yet.
Thank you so much, Elizabeth. Really appreciate it. I'm having difficulty asking questions without them sounding like an exam. But the question I'm about to ask, I would just really like your information, okay. But it isn't a test. I'm interested to know whether part of your work encompasses the human rights discourse. Do you use in your work? Do you talk about human rights? And if so, could you elaborate a little bit? And if not, thank you.
We are gradually coming round to the human rights discourse. Of course, everybody knows about the UN conventions, and we're cognizant of all of those things, and we want to be compliant in how we do things and how we think about things. But rights the word rights has been problematic for some people. You know, they've kind of got a little bit of a scared thing about it. I mean, you know, you've done a little publication yourselves, I think, around the Bill of Rights and what frightens people about rights. You know, it's something that is hard to discover what it is about rights that frightens people. But I think maybe that's just it's a lot of capacity building we have to do ourselves with people we're working with. We have to explain better what rights are about, and that the rights duty balance is between rights bearers, all of us, and those who have a duty to ensure that those rights aren't infringed or denied. Our most recent campaign, which is about the right to get a diagnosis, it's called Right to Know. And that is a play on words, obviously, about the rights issue, but also the right thing to do in terms of the proper thing to do. And the fact that people have a right to know if they have a serious condition like dementia. To be clear in answer to your question, we're getting there, but we've got some way to go. But we certainly don't have any problem with rights. We just haven't been using rights language to now. You know, we haven't been using it as much as we might have, and I think we're getting to the point where we're feeling, well, actually, you know, people are much more comfortable with the idea of you know, a right to health and a right to a diagnosis, and that's something that we will be promoting because it's a very powerful means of campaigning, and it's also a very strong message to give people that this is a rights issue. This is not about have we got the funds, can we afford it, do we deserve it? It's a human right to have health care, and we don't balk at that.
Thanks a lot, Elizabeth. Thank you.
Okay.
I'm actually going to ask you a couple of exam questions as
dear.
well, but they will be.
I didn't get my 11 plus now. This is embarrassing.
It's just to build on the idea of the involvement and participation.
Yes.
10,000 Voices, are you familiar with it? Were you involved in it?
No, I wasn't involved in it.
Has there been any other examples where the trust, and I'm thinking now on the health side rather than the social care side, have ever come and talked to Alzheimer's Society about either an emergency department or in broader ways about what the needs of people with dementia, using that in its broader sense, are? Are there engagement mechanisms that you have in any of the kind of processes?
Well, now, many of my colleagues would be working directly with the trusts. I mean, my remit would be policy, public affairs, kind of campaigning. So I wouldn't be in hands-on discussions or one-to-one discussions with trust personnel. But I know that many of my colleagues are in regular contact with the trust. We provide services for the trust, and those conversations are happening all the time, and I certainly think that the trusts would want people to be involved in a meaningful way in decisions and planning, and certainly that's the way the Alzheimer's Society likes to do things. I mean, when we're starting out with any kind of a program, we want to know what people with dementia and their family carers think and what they think is best. And if we have a divergent view, we want to persuade them. We don't want to push them. We want to persuade them, and if we can't persuade them, we have to adapt our views.
And because of your, I suspect, unique role in terms of how many policy officers you might have in the Alzheimer's Society, so you may not know the answer, but I think it's very helpful to have a kind of informal. And have you any sense, though, whether there are formal mechanisms alongside the service delivery, working with trusts, possibly being funded by trusts to do things, where obviously there is a two-way communication about how services are run? Have you any sense of whether there are formal mechanisms?
I don't actually. I'm not aware of what formal mechanisms are in place, but I could certainly find that out through talking to my colleagues, but I can't tell you about them just now. Fine. Okay. Will I write that down?
I think I've moved from asking you a couple of exam questions to setting you some homework, even worse. Is there anything else that you'd like to say to us, or you think we've missed before you finish?
I just think probably just to emphasise, from our point of view, the bottom line is, what we want is health service, and you're talking about emergency health care here, but I think we can't just look at things in, this is what we're looking at today, and there's nothing before it and there's nothing after it. We have to think, particularly from perspective of people with dementia, that this is a continuum and that it is very much a holistic process. It's not an event. Getting a diagnosis early, getting early intervention and properly resourced early on will pay dividends, not just economic, but human dividends down the line, long term.
Thank you. That's really helpful. As we've said to all those who've given evidence, if you want to augment your evidence with any material, and I think we probably have set you some homework in terms of international or local or best practice around the end-of-life care, and whether there are some formal mechanisms or not would be really helpful to us. So if that's possible, that's great. And can I just say thank you very much again for your evidence. That's been really helpful. Thank you.